So today we are going to talk about hemoptysis in children. A few days back, one of my subscribers, Dr. Madhuri Reddy, asked me to make a lecture on hemoptysis. So I decided to make this small video on the cause of hemoptysis in children. So Dr. Madhuri, if you are watching this is for you. Okay, and I will try my level best to explain the causes of hemoptysis and how do we generally manage it in the pediatric practice. But if you've got any questions or something, please feel free to ask your questions in the comment section below, and I'll be more than happy to answer those questions. So without further ado, let's dive in and get started. So the first question is, what is hemoptysis? Now, hemoptysis basically is defined as bringing up blood, coughing of blood, or expectoration of blood, which is coming from the lower respiratory tract. So, lower respiratory tract basically is defined below the levels of the vocal cords. So, any blood that is coming from the respiratory tree, which is originating from below the level of the vocal cords, is known as hemoptysis. Now, hemoptysis can be classified into mild, moderate, or severe. So, in a 24 hours time period, if somebody is bringing up less than 20 mils of blood through expectoration, we call it as mild hemoptysis. If somebody who's got between 20 mils and 200 mils, we will call it moderate. And beyond that would be severe. Some books classify as life-threatening severe form of hemoptysis as well. That means more than 600 mils of blood being expectorated in a 24 hours time period. But nevertheless, this classification is a bit arbitrary because it's not easy to measure the amount of blood. So it basically depends on the clinician discretion and the clinical presentation of the child. So hemoptysis, by simple definition, is bringing up or coughing up or expectorating blood which is originating from below the level of vocal cords or lower respiratory tract. Now, the first important thing is to differentiate it from what we call as pseudohemoptysis. Now, pseudohemoptysis means that obviously the child is coughing up blood, but that blood is coming from above the level of the vocal cord. So it could be from the pharynx, it could be from the tonsils, it could be from the adenoids, or sometimes it might be because of hematemesis, which is relatively more frequent as compared to hemoptysis. So what happens is that the child basically is bringing up blood through the digestive tract, maybe because of viral gastritis or maybe because of esophagitis, but because at the same time there is an element of cough as well, and the cough brings that little bit of blood which actually originated from the digestive tract. It looks like that the child had hemoptysis. So these basically coughing up of blood which is coming from either the upper respiratory tract or from the digestive tract but looks like hemoptysis is known as pseudohemoptysis. So it's important for the doctor, if somebody says that this child has got hemoptysis, you have to differentiate whether this is true hemoptysis or pseudohemoptysis. In other words, you have to ascertain whether this blood is coming from the lower respiratory tract or either it's coming from the upper respiratory tract or either from the digestive tract. So this is very, very important because once you know where the blood is coming from, it's easy for you to diagnose and manage the underlying cause. Moving on to the pathophysiology of hemoptysis. As we said, that hemoptysis is basically expectoration of blood which is coming from the lower respiratory tract. So you need to know where is the blood coming from. Basically, the lower respiratory tract has got two types of blood circulation. One is what we call as the high pressure circuit. Now, the high pressure circuit basically is the oxygenated blood which is being supplied to the lung tissue. Now, these are small arteries which are originating either from the aorta or are the branches of the intercostal arteries, and they are bringing up very like oxygenated blood and supplying the lung parenchyma and the supporting structures. Then we also have got the low pressure circuit which brings the most of the volume into the respiratory tract, blood volume into the respiratory tract. So the low pressure circuit basically is your deoxygenated blood which is coming through the right ventricle, and it is coming for the purpose of getting oxygenated and getting carbon dioxide offloaded. So that is the low pressure circuit. Now, hemoptysis can occur either because of bleed in the high pressure circuit or in the low pressure circuit. Now remember, most of the times low pressure circuits, because there's not much pressure, this would lead to a little bit of bleed into the smaller airways, into the terminal bronchioles, or into the alveolar sac. While the high pressure circuit would cause massive bleeding because there's a high pressure beneath that, and there are more chances of bringing that blood up in the form of expectoration, because in any case blood is quite irritant for the airways. In any case, whether the blood is coming from the low pressure circuit or from the high pressure circuit, it is quite an irritant to the airways, and that would invoke cough. And if the child has got enough power to bring that cough up, you might see that the child is bringing up blood as well. So two types of circulation: the high pressure bronchial circulation and the low pressure pulmonary circulation, which is originating from the right ventricle. And we have to differentiate between these two. As I told you, that most of the times the low pressure circuit would not give you hemoptysis because the pressure is quite low, but in the high pressure circuit there are more chances, because the even if there is a tiny bleed, that would lead to a lot of bleeding, and there would be a lot of irritation, and more irritation means more chances of coughing and more chances of bringing it up where it can be visibly seen by the patient, by their parent, or by the doctor. Okay, so that's a little bit about the pathophysiology of hemoptysis. So let's move on and talk about the etiology, the cause of hemoptysis. Now there are so many causes of hemoptysis, so many. The list is quite big one, and obviously, as a pediatrician, it's not easy to remember all these causes at the top of your head. So to make it easy, we classify the causes according to the age groups. So the first age group are those like neonates and infants, so less than 1 year of age. And then we take the toddlers, that would be between 1 and let's say 2.5, 3 years of age, maybe 3.5. And then we have got the school age children, like which would be probably 4, 5 years and onward, even the adolescents. Now, remember the small age groups, that is the infants, neonates and infants, and the toddlers. They do not have much developed musculature of the chest, so it's not easy for them. They do not have that tussive power to bring up expectoration. So even if they are coughing, that is not a high pressure cough where things can be propelled out of the respiratory tract. So even if there is a bit of hemoptysis, there are more chances that these children would actually swallow up. So if a little bit of blood is coming up, they would swallow up, and then it might appear in the stools in the form of, like, brown discoloration or cola colored discoloration of the stool and things like that, or maybe like black tarry stools, depending whether it has been processed by the acid or not. So small kids have got less chances of bringing up blood because they do not have much tussive power. Nevertheless, if it occurs and somehow the complaint is brought in front of you, remember the common causes in the early age group, that is the infants, are mostly congenital malformations. So these could be the congenital malformations of the airways or of the cardiovascular system. So the most common causes are what? Congenital malformations. Like, for example, if there is bronchopulmonary dysplasia, dysplastic cells, more chances of, like, abnormal blood vessels over there, and they can get eroded and can cause hemoptysis. Sometimes they might have other abnormal what you call development of the lungs. For example, a bronchogenic cyst. So bronchogenic cysts can have abnormal blood supply, and that can sometimes rupture, giving hemoptysis. Or there can be other different types of pulmonary malformations. For example, pulmonary hemangiomas. They can have apparent blood vessels traversing somewhere through the bronchioles, and that can get eroded because of many factors and can lead to hemoptysis. The other is the congenital malformations of the cardiovascular system. So congenital, like, congenital heart disease in various forms, which leads to elevated right-sided pressures. For example, pulmonary hypertension, which can occur because of various conditions, or all those conditions in which the right pressures would increase, like for example those types of congenital heart disease which have got left to right shunts, which lead to higher pressures in the pulmonary circulation. So that might lead to breakage of the vasculature and cause hemoptysis. Similarly, if the pressure goes down into the smaller vessels into the lungs, for example, in pulmonary edema, there are more chances that the child might develop or the infant might develop uh, hemoptysis. So remember, if you see a child less than 1 year of age who has got hemoptysis, then think of congenital malformations of the airways or congenital heart disease. And let's say if these two conditions are ruled out, then start thinking about coagulation disorders or hematological disorders which might lead to hemoptysis. So you might have to look into the coagulation profile and do certain types of tests within the coagulation profile and further take it from there. So these are the three broader categories. Rarely it can be caused by other things as infections as well, but by and large it's the congenital malformations and coagulation or hematological abnormalities that would cause hemoptysis in children less than 1 year of age. Now coming down to the toddlers. Now toddlers, obviously they are slightly bigger than the infants, so they've got more, like the incidence of respiratory tract infections are more in these kids, and especially if they develop again and again like lower respiratory tract infections, they have got more chances because the infection leads to inflammation. Inflammation leads to more blood coming into that particular area, and sometimes because of the severe infection and inflammation, blood vessels can get eroded, leading to hemoptysis. So lower respiratory tract infections are number one reason for hemoptysis in the toddler age group. The second important cause in this age group could be a chronic foreign body. Now, obviously, foreign bodies, if there is an acute foreign body aspiration, that usually presents more with choking and cough and difficulty in breathing. And obviously, the history and the clinical examination usually points towards that direction. But sometimes the history is not that much obvious, and it might lead to chronic foreign body. So the more chronic it is, it's not easy to recall if there was a choking episode or something. The child might present with the repeated chest infections, or that child might present with hemoptysis. And hemoptysis is relatively more common if the chronic foreign body is of vegetable origin. So if the child was eating something, let's say grape or corn or something, and it went, he aspirated, and somehow that went unnoticed, and there's a time over that he might develop uh, infections, repeated infection. And if hemoptysis occur, there are more chances that these types of vegetable foreign body would lead to hemoptysis. So keep that in mind. In school age going children, again the etiology depends from region to region. In developing countries, tuberculosis is still the most common cause of hemoptysis. So it's like a bacterial infection, mycobacterial infection, which is quite common in the poor countries, and that should be at the top of your head. But in developed countries, there are so many things you can think of. Repeated viral infections leading to inflammation that can cause hemoptysis. You can think of the lower respiratory tract infection. Again, a lot depends on the clinical presentation. Sometimes in developing countries, we are seeing a more incidence of autoimmune disorders. For example, a child who is presenting with repeated asthma-like symptoms, and let's say he's also exhibiting a phenotype of asthma with, let's say, high eosinophil count, and he improves with steroids, but as soon as you stop the steroid, he goes back, and he's got like a sort of a repeated history of having asthmatic attacks. And he also presents, let's say, with some renal involvement in the form of, let's say, hematuria or proteinuria. Then you should start thinking of autoimmune disorders. Like, for example, in this particular case, if a child has got a history of repeated asthma, high eosinophil counts, and some renal involvement, you can be thinking of what we call as eosinophilic granulomatosis with polyangiitis, which was, I think, a few years back known as Jerk-Strauss syndrome. Jerk-Strauss syndrome. So you might have to do the p-ANCA antibodies test to confirm the diagnosis. So autoimmune disease. Similarly, if somebody has got repeated sinusitis, saddle nose deformity, has got some renal involvement, then you can be thinking of simple granulomatosis with polyangiitis, which was called Wegener's granulomatosis. So Wegener's granulomatosis are C ANCA positive, like the Church class is P ANCA positive, the Wegener's granulomatosis is C ANCA positive. Or if there is just hemoptysis and hematuria, you can even think of good pasture syndrome. So all these conditions are autoimmune conditions. So Wegener's granulomatosis, or we also call it granulomatosis polyangiitis, Church syndrome, which is known as eosinophilic granulomatosis polyangiitis, or uh, good pasture syndrome, in which there is in which there is pulmonary and renal involvement. They are all autoimmune disorders. They all have got small vessel vasculitis, and they can, because there is vasculitis, inflammation of the blood vessel, they can present with varying degree of hemoptysis. So autoimmune conditions you can think of, especially in developing countries where the incidence of these things are increasing because of various factors. I don't want to go into the details of the environmental, the nutritional, the other things that is leading to an increased incidence of these autoimmune disorders. But nevertheless, in poor countries or developing countries, you think more of chronic infections, especially tuberculosis or other chronic infections of the lungs. So remember, it's easy if you try to break down the etiology according to the age group. So the causes in the early age group, mostly congenital malformations of the pulmonary system and the cardiovascular system, followed by hematological disorders. Then in the toddler age group, think of the chronic foreign body aspirations, repeated infections, things like that. And then in the school age going children, again, you'd be thinking of infections and autoimmune etiologies. And then there are further so many diseases under each of these categories. So again, you don't need to remember each and every one of them, but just give you a few as an example, so that at least you can think about those things. Now, once you, let's say you are thinking about the etiology, the child is in front of you, how do you investigate? What would you do? Like somebody who's got hemoptysis, and like, okay, well, this is hemoptysis, and then you are thinking these diseases might be the causes. So where do you start from? The most important things, again, to start, like, you have to take a very good history and do a complete physical examination. So it doesn't matter if this, you say like the child has got hemoptysis, so I only need to listen to the chest. I mean, do a full head to toe examination just to see if the other systems are involved or not. Like, for example, you have to check the gastrointestinal system as well. You have to check the musculoskeletal system as well. You have to check the central nervous system. You have to look at the skin if there are any external hallmarks of any vasculitic uh, etiology, and so on and so forth. You have to do a complete examination after taking a very good history. Now, once you have taken a history, you have done your examination, then you need to start from somewhere. So the important starting point is full blood counts. In full blood count, you are looking basically at the white blood cell count. You're looking at the hematological parameters in the form of red blood cells and hemoglobin. For example, if somebody has got massive hemoglobin drop, that might be because of hemoptysis, like severe hemoptysis. You look if there is any drop in hemoglobin. You look if there is an increase in white blood cell count, which might signify an infection with a shift towards the, let's say, increase in the neutrophils. You also look at the platelet counts. You also see if there are any other hallmarks of hematological problems. You also look at the coagulation profile to see if they are deranged, which means that there is some problem with the coagulation factors. So it's important to start with the full blood count, and you also look at the coagulation profile. And then you, from there, whatever is the presentation, you can go for more targeted investigation. In all these cases where if somebody is presenting him, also look at the renal function test. So, and also don't forget the urine dip to see if there is any proteinuria or hematuria, because if there is proteinuria or hematuria, it means that there is renal involvement, and if there is pulmonary and renal involvement, you should start thinking of autoimmune etiologies. So the targeted things comes later on, once you have narrowed down your differentials. For example, if you are thinking of eosinophilic granulomatosis with polyangiitis, probably you would order what we call as a P-ANCA test. If you are thinking of Wegener's granulomatosis, you will be doing a C-ANCA antibodies test. If you are thinking of Goodpasture syndrome, anti-basement membrane antibodies have to be done. So again, these are specialized tests. And again, as you narrow down your differentials, that would be guiding which type of test you need to do. Once you have done with the basic investigations and some target investigation, there are other modalities which you can use to find out or further create hemoptysis, chest x-ray being one of them. So starting with radiological techniques, chest x-ray is usually available in all the hospitals, and you must do a chest x-ray, because if chest x-ray shows patches or consolidation, that means there is an infection. The chest x-ray in certain cases might show foreign bodies, especially if they're radiopaque foreign bodies, or if there are changing densities. If you compare with some previous records, you might think of vasculitis. Similarly, if chest x-ray not giving you enough information, you can go for a high resolution spiral CT, which can, like, further sort of visualize the vasculature of the lungs, and can give you a clue where the, let's say, where the bleeding is coming from. Similarly, sometimes you might have to do, if you are thinking that there might be something wrong with the cardiovascular system, then you might have to do an echo to see if there are increased pressures on the right side of the heart, whether there is like sort of any leakage around the valves, so on and so forth. So imaging techniques starting from chest x-ray, high resolution spiral CT of the chest, and then if in case if needed, echocardiography to rule out heart problems which can present with hemoptysis, you can do depending on the clinical presentation. One important thing that can be done, which can be sometimes diagnostic as well as therapeutic, is doing a fiber optic bronchoscopy. Now, again, if you are suspecting a foreign body, let's say, then it's better to go with a rigid bronchoscope, because rigid bronchoscope can easily remove foreign bodies from the respiratory tract of the children. But if you're doing it for diagnostic purposes, whether you want to do want to take some washings from the respiratory tree in the forms of bile to see what is causing or where this blood is coming from, then fiber optic bronchoscopy can be diagnostic as well as therapeutic. In certain cases, for example, if there is a bleeding point which is identified, that can be embolized with the help of the bronchoscope as well. So bronchoscopy, fiber optic bronchoscopy or rigid bronchoscopy can be therapeutic as well as diagnostic. So you can diagnose and you can treat at the same time. So this is also a very good modality to diagnose and treat the cause of hemoptysis in children depending on the clinical presentation. How do you treat hemoptysis? Most of the times hemoptysis would be mild, so you don't need to do anything per se about the hemoptysis itself. You need to see what is the cause of hemoptysis and then treat it. You treat the underlying cause and the problem would be solved. But let's say somebody who has got massive hemoptysis or life-threatening hemoptysis, where, like, let's say the hemoptysis is more than 200 mils in 24 hours or more than 600 mils in 24 hours, and there is chances that the child might exsanguinate or might develop complications because of ongoing bleeding, then your ABCDs should kick in. You need to stabilize the child first. So obviously you look at the airway, you have to look at the breathing, you have to maintain the circulation by giving whatever you want to give, fluids you want to give, like blood products or whatever. Your hospital protocols and the APLS protocols usually guide you in sort of a treating these types of crashing children. So just follow the APLS, EPLS, PALS, whatever your local guidelines are as far as the initial stabilization in case of massive or life-threatening hemoptysis is concerned. Then once a child is stabilized, general approach in case of massive or life-threatening is to identify the bleed source. So the bleeding source has to be identified, and in such cases the most important thing is to do bronchoscopy, because it can be therapeutic as well as diagnostic. So that is important. And sometimes you might have to involve other teams as well, multidisciplinary teams, because as a pediatrician you are not able to do bronchoscopies. You are not able to do, like, let's say fluorovisualization technique or something. So you might have to involve the ENT, you might have to involve the cardiothoracics, depending on your local protocols, whatever you have got it in place. Then coming down to pharmacological treatment. Pharmacological treatment again depends, like if you want to treat it with medications, you need to know what has been the cause. For example, if infection is causing it, you will treat it with antibiotics. If you think there is repeated viral wheeze and inflammation, you might have to give steroids and bronchodilators to treat the underlying condition so that the hemoptysis starts. So whatever is the cause, you have to treat it with the relevant medications. uh, Non-pharmacological interventions, again, if let's say we talked about this diagnostic and therapeutic bronchoscopy, in case if a child presents severely with massive or life-threatening hemoptysis. But sometimes, if even if they do not have got life-threatening or massive hemoptysis, but they are presenting it again and again, it becomes a challenge. Then in that particular case, it's important to do a diagnostic and therapeutic bronchoscopy to see where the blood is coming from and manage it accordingly. Sometimes there might be a vessel which is the culprit, so in that particular case it might need to be embolized. So vascular embolization can be done. These are usually done in specialized centers with specialized techniques and instruments. And once it is done, it's also important, if the hemoptysis has been treated, the child needs to be closely observed so that in case any complications or any problems arises, they can be dealt in an effective and timely manner. So this was all about hemoptysis in pediatric practice. I just told you what is actually the definition of a hemoptysis. It's very important that we have to differentiate it from pseudohemoptysis. If somebody says hemoptysis, the first thing is you examine the throat, you examine the nose, and you ask if there are any gastrointestinal symptoms which might be responsible for what we call a pseudohemoptysis. That is either the blood coming from the upper airways or from the digestive tract. And if it is a real hemoptysis, then you have to take a detailed history, you have to do a physical examination, you might have to investigate depending on the whatever is the presentation. And you can start with simple blood tests like full blood count, coagulation profile, chest x-ray, and then depending as you narrow down your differentials, you can think of other modalities if you want to, or you can refer the child. Or if you find that there is a trivial reason, for example a chest infection or something, then obviously you can manage it accordingly, uh, by giving them antibiotics or whatever you think is causing it, you just treat it. So I hope you have learned something about the etiology, the classification, and management of hemoptysis in pediatric practice. If you still got any questions, put it down in the comment section below. As I said earlier, I will be more than happy to answer your queries and questions. And then you have a very good day. I'm signing off. Take care. Bye bye.